Rikers Island operates as New York City's primary jail complex. It houses people awaiting trial and people serving short sentences. The population changes daily. Intake and release are constant. Movement defines how the jail functions. One of the most frequent forms of movement involves medical care. Many detainees require treatment that cannot be provided inside the jail. Chronic illness, mental health care, injuries, and specialist consultations require transport to outside hospitals and clinics. These trips are routine. They happen every day. Medical transport vehicles include vans, buses, and ambulances operated by the Department of Correction and contracted providers. Detainees are escorted by correction officers. They leave the island, travel through public streets, enter civilian medical facilities, receive treatment, and return to custody. Medical transport is essential. It is also one of the most vulnerable points in Rikers' security system. Each transport removes a detainee from the controlled environment of the jail. Inside Rikers, movement is monitored. Cameras are fixed. Searches are expected. Outside the jail, conditions change. Oversight becomes fragmented. Responsibility is divided among multiple actors. Custody transfers repeatedly during a single medical trip. Housing officers release detainees. Transport officers assume responsibility. Medical staff provide documentation. Hospital personnel control treatment spaces. No single group maintains full oversight from start to finish. Accountability weakens at each handoff. Department policy requires detainees to be searched before leaving the jail. Searches are also required upon return. Vehicles are supposed to be inspected before and after transport. These procedures exist on paper. Investigations show they are not applied consistently. Staffing shortages affect every stage of the process. Transport officers manage schedules, restraints, paperwork, and coordination with hospitals. Time pressure is constant. Medical appointments run late. Vehicles wait for hours. Fatigue becomes routine. Under these conditions, searches are shortened or skipped. Vehicle inspections are irregular. Supervisors are often absent. Trust replaces verification. Medical transports follow predictable patterns. Some detainees attend recurring appointments several times a week. Dialysis, wound care, psychiatric evaluations, and physical therapy require repeated trips. Certain hospitals receive detainees regularly. Routes and schedules become familiar. Predictability creates opportunity. Investigations later establish that medical transport becomes one of the primary entry points for contraband at Rikers. Drugs, tobacco, cell phones, and weapons are smuggled into the jail using medical trips as cover. This occurs repeatedly and across multiple years. Detainees use simple concealment methods. Small packages are hidden in clothing seams, waistbands, socks, and shoes. Elastic bandages provide cover. Braces and wraps conceal hollow spaces. Legitimate medical supplies are altered to hide contraband. Some detainees conceal items on their bodies. Searches fail to detect them when procedures are rushed or incomplete. The methods succeed because enforcement is inconsistent. Public hospitals create additional gaps. Examination rooms limit visibility. Curtains block sight lines. Restrooms provide privacy. Waiting areas are crowded and difficult to monitor. Officers are often responsible for more than one detainee at a time. Hospital staff focus on medical treatment. Security is not their role. Civilian environments are not designed for custodial supervision. These conditions are necessary for care. They also create blind spots. During hospital visits, detainees receive items from outside accomplices. Investigations document exchanges that occur during brief moments of reduced supervision. These exchanges are fast. Detection is rare. Documentation is minimal. In other cases, contraband is introduced by staff. Multiple investigations confirm the involvement of correction officers and civilian employees in medical transport smuggling rings. Some officers accept cash payments. Others receive favors or assistance outside work. Some are pressured. Motivations vary. The behavior is consistent. Medical transport assignments provide opportunity. Once vehicles leave the island, supervision decreases sharply. Vehicle interiors are controlled by staff. Storage compartments, medical equipment bags, and seat cushions are rarely inspected. Logs are incomplete or inaccurate. Contraband is hidden inside vehicles and transported back onto the island. Upon return, detainees are processed quickly to avoid disrupting housing operations. Searches are often cursory. The assumption is that medical facilities are controlled environments. Investigations confirm that assumption is incorrect. Cell phones are the most common items smuggled through medical transport. Their small size makes concealment easy. Their value inside the jail is high. Phones allow unmonitored communication with people outside the facility. Once inside housing units, phones are sold, rented, or controlled by dominant groups. They are used to coordinate drug distribution, organize violence, intimidate witnesses, and manage outside criminal activity. Phone usage undermines institutional control. Investigators rely heavily on phone records. Call data is compared with medical transport schedules. Patterns emerge. Calls originate inside housing units shortly after medical returns. The timing is consistent. The source is identifiable. Drugs follow similar routes. Synthetic cannabinoids are common because they require small quantities. Diverted prescription pills are also prevalent. Some detainees exaggerate symptoms to obtain medications that can be traded. Medical transport facilitates this flow. Tobacco remains a major commodity despite long-standing bans. Demand is constant. Prices fluctuate based on supply. Medical transport increases availability. Weapons are less frequently smuggled but carry greater risk. Small blades, metal fragments, and cutting tools are introduced in parts. Assembly occurs inside housing units. Even limited weapons significantly increase the severity of assaults. As contraband spreads, violence increases. Gang influence expands. Informal economies grow. Debts accumulate. Extortion becomes common. Disputes escalate rapidly. Incident reports document rising assault rates against detainees and staff. Oversight bodies track these trends. Internal audits link spikes in violence to periods of increased medical transport activity. Contraband recoveries cluster around medical return times. The correlation is noted repeatedly. The New York City Department of Investigation opens formal inquiries. Federal authorities also become involved. Investigators review transport logs, surveillance footage, disciplinary records, and phone data. Cooperating witnesses provide confirmation. Court filings describe smuggling through medical transport as routine rather than exceptional. Payments are exchanged. Schedules are coordinated. The process is deliberate. Medical transport is chosen because it bypasses internal security systems. Correction officers, civilian staff, and outside accomplices are charged with bribery, conspiracy, and trafficking contraband. Arrests confirm what oversight reports suggest. The problem is not isolated misconduct. It is organized activity enabled by weak controls. Public reporting increases pressure on leadership. Officials acknowledge failures. Reforms are announced. Policies are revised. Training is updated. Oversight bodies monitor compliance. Progress is uneven. Staffing shortages persist. Medical needs continue. Transports cannot be eliminated. Searches remain inconsistent. Vehicle inspections remain irregular. Enforcement varies by shift and supervisor. Oversight reports describe the problem as structural. Medical transport combines 3 risk factors: movement outside secure space, predictable schedules, limited supervision. Together, these conditions create a reliable entry point for contraband. The evidence shows that instability at Rikers is not driven solely by detainee behavior. It is enabled by institutional failure and insider corruption. When staff participate in smuggling, authority collapses. When procedures are ignored, risk multiplies. Medical transport remains essential to detainee care. It also remains a vulnerability. Every investigation reinforces the same conclusion. Without strict, enforced oversight, contraband continues to enter the jail. The consequences are documented in arrest records, incident data, and oversight findings. They are measurable. They are ongoing.